Good morning to those of you here and online. My name is Lisa Brackbill, and I'm going to be talking to you today about how I believe we can see all state screening for metachromatic leukodystrophy by 2029. Can would be the operative word. Oh, I guess I'm in charge. There we go. Here are my disclosures. For those of you who do not know me, as I said, my name is Lisa Brackbill. I live in Hershey, Pennsylvania. I have been married to my husband, who's right here, Brennan, since 2010. We have 3 children, Victoria, Isaiah, and Caleb. I have a bachelor's of political science, and I just finished my master's in strategic communication last month. So I'm very happy to have that behind me. I am an author, an advocate for newborn screening, and I helped start the Leukodystrophy Newborn Screening Action Network in 2020. My daughter, Victoria, or Tori, is the reason that I have become an expert in newborn screening and newborn screening advocacy in the United States. It is because of her that I fought over the course of 5 years in Pennsylvania with 3 different bills to reform our newborn screening system, making our program one of the strongest in the country. It is because of Tori that I persisted in advocating to the Newborn Screening Advisory Board in Pennsylvania and convinced them to add Krabbe disease, making Pennsylvania the 9th state to start screening for Krabbe. And it is because of Tori that we identified 4 babies with Krabbe disease in the first 7 months of screening. Just wait, including identical twins born on her birthday a mere 2 months after we started screening. Since she gets the credit, I always like to honor her. So before I begin about how we're actually going to do this quote came to mind as I was preparing to share this same message about a month ago in Philadelphia. This was originally said by a theologian to try to get Christians to get along. And I actually thought it really applies well to newborn screening advocacy because it can be a pretty complicated thing. So in essentials, unity; in non-essentials, liberty; and in all things, charity. So what does this mean? In the essentials, there must be unity in this community. For the work we are doing, unity includes communication, collaboration, coordination, transparency, and inclusion. The essentials involve those directly impacted by MLD, the parents, families, and patients themselves, who will likely be advocating in their respective states. But it also includes all of us who will be working together in our specialties and our expertise to make this a reality. We must remember what matters and to put aside what doesn't. 3 different things here. In the non-essentials, there must be freedom to do what must be done in each respective state to make newborn screening for MLD a reality. Some states will require more effort than others, and we must be flexible while also following the lead and the processes established by the states themselves. We must recognize that both science and bureaucracy are always changing, including since I made these slides, and we must go with that flow. And in all things, there must be charity, which we will define for this presentation as kindness and respect. That isn't only toward each other as we advocate in this, which can be a very emotional and difficult journey, but also toward the public health labs and the state departments of health and the processes and limitations that they have. We must not steamroll the public health labs in our quest for universal newborn screening for MLD. This means using legislative mandate as little as possible. Too many poorly written laws have negatively impacted the public health and newborn screening system, and I truly believe that we must not do the same as we seek to add MLD. 48 states have newborn screening advisory boards that have the power to add conditions, and they have the established processes for adding those conditions. So let's respect those and work within them. So today, we will reverse the order of the quote and focus first on the non-essentials, which are the challenges of a complex newborn screening system and the plan for each state, which I know is really what you all care about most. The second part will discuss the essentials, why listening and collaboration are critical, and the importance of including families in all we do, because believe it or not, sometimes we get left behind. It is my hope that you will feel encouraged, above all, by the strategic analysis that I have built and created, and be reminded of the importance of unity as we begin this journey. So as you may be aware, and if you're not, I'm going to be sharing Newborn Screening 101 tomorrow afternoon. We face a lot of challenges when it comes to seeking to add a condition to each state's newborn screening panel. The strategic plan I will present today takes all of these into account, plus more. But these are just some of the complexities. So states operate differently, including the numbers of conditions that they screen for, which we're actually also in the process of fixing. I was in DC to do that this week. The process of adding conditions in each state, the technology that they use for newborn screening, which impacts how easily they can add conditions, especially LSDs, whether they do the newborn screening in-house or if they outsource to somebody like Revity. We also have to take into consideration the biases of decision makers who may have outdated information about a condition, as I experienced in Pennsylvania with Krabbe disease, and it's up to us to convince them and show them the data and the evidence to convince them otherwise. And then how each state handles RUSP conditions. So there's so much that goes into this. So with that said, let's dive in. So when we first started LDMBS 4 years ago, it started with this spreadsheet. I had been tasked with learning as much as I could about every single state's, well, originally Maria said the whole world. I took it down to the states, how each newborn screening program operated. And I started with a spreadsheet because how else do you handle tons of information? I don't know. This is how I do it. But I quickly realized as I was creating this that when parent advocates looked at the spreadsheet, this is often how they felt. And so using my master's degree, I decided that it was more important that I make this information accessible and usable. And so last fall, while actually procrastinating on a paper, I spent hours creating the strategic plan because I really wanted to provide hope and clarity and not confusion to fellow parent advocates. So if you want, you can scan this. If not, it's publicly available at ldmbs.org, the plan I'm about to present. Give you a second if you want. Because I'm not gonna, the plan does not translate well to slides. So if you want to see the actual beautiful plan, that you can do that. Okay, so this is what you will see when you open the document, some of the pages. So we start with an overview of the current landscape, and thanks to Dr. Adang's recommendation, there's always a date right there with when this was last updated. We broke it then, well, Marley helped me too. This is not just me, but we then broke it down into categories of states. And I was able to then use all of that spreadsheet, use that data to pull out the ones that I think are the easiest to accomplish first. So we'll go into those a little bit now. But I truly believe, based on all of my my knowledge and my data, that we can, I'm not saying we will, we can see universal screening for MLD in the United States by 2029. This is incredibly ambitious, but I hope that I can convince you that it's possible. So this is one of those slides that's already changed because we did officially submit the RUSP nomination yesterday, which means we are on track. And I did hear from HRSA that it's on the agenda for the August 8th and 9th meeting. The ACHDNC will review our package and vote on whether or not to send MLD into full evidence review, which is a 9-month process. So the clock officially will begin on August 8th or 9th, which means that we can expect a vote in May. So May 8th or 9th of 2025 is likely when the ACHDNC will vote whether or not to approve MLD for addition to the RUSP. After that, it does take another about 6 months. As an example, we are still waiting for the official word from the Secretary of Health on adding Krabbe disease to the RUSP, and he has 30 more days to do it. We will not be sad if he waits 30 more days because Tori's birthday is July 30th. So if he waits till our daughter's birthday, that would be okay. Anyway, I'm just kidding. We obviously want RUSP alignment faster. In the meantime, Tennessee is expected to begin their newborn screening pilot in the summer or fall, probably more like fall at this point. Illinois is expected to begin universal screening for MLD in September. In addition, next month, Pennsylvania will likely be deciding whether or not they are going to pursue MLD. It is my hope that Pennsylvania can be the first one, because I live there and we have CHOP, and why not? Why not have us be first? We can also add conditions in 6 months. So I know this is a lot, but this is a summary of the expected implementation. So the states, let me see. The states in blue are what we can expect between 2024 to 26. The ones in red, I expect in 27. Green are 28. And then the ones in blue, I'm giving them until 29 because they just have a history of waiting. And again, some of that's because of their own limitations within their newborn screening systems. So again, I told you this did not translate well to slides, but in that plan, I listed out the states with RUSP alignment policies, and recommended uniform screening panel. So that is something that under the Health Resources and Services Administration, I actually can't remember what HRSA stands for. The federal level, there's a committee that reviews evidence and they decide which conditions they recommend should be screened for in every state. This began in 2003. The process began in 2003. And it was supposed to increase uniformity between states, but not everybody adheres to it because we know how that goes, right? Every state wants to do their own thing, but it's helping. So, in the actual plan, there are links where you see timeline to the actual laws, if they have a RUSP alignment law in place. There are different notes about states like Delaware uses Revity as their newborn screening lab. Revity already has the capability to screen for MLD, so Delaware therefore could potentially screen earlier than this. But what they told me in a survey was that because they do not have a specialist in this state, they don't want to screen for it. We hear that all the time. So continuing with RUSP alignment policies, I also noted the states that are hub states. So Iowa, for example, which just approved screening for Krabbe disease last week, they screen for North Dakota, South Dakota, and Alaska. So once Iowa's advisory board agrees to screen for MLD, or if they wait until their RUSP alignment timeline, we can then pursue those other states. So that's the last slide of RUSP alignment states. This is something that I'm so glad the rare disease community as a whole has been working on for years, usually led by the Every Life Foundation, because it benefits us as well. So we don't have to be doing all this hard work of getting states to agree to screen for everything on the RUSP. These states have condition nomination processes with publicly available forms that make it, I was gonna say easy. It still is basically like a mini RUSP nomination. But we actually have already submitted to Minnesota and Pennsylvania using these processes. Minnesota is expected to review it, I believe, in September, maybe it's October. And Minnesota was very quick to implement Krabbe disease, so I think they could do MLD quickly as well. So these are the states that I believe would be a good place to start because we already have the nomination package. We can basically copy paste to a lot of these states. Oh, okay, Colorado moved over to its own line, sorry. I don't know why it did that. These states, and I tried not to duplicate states. So there are other states with advisory boards, but these states do not have specific RUSP alignment legislation, but they do have active advisory boards, and we know advocates in these states. A lot of states don't like to consider adding a condition that's not on the RUSP if they don't have families within the state who have been impacted by the condition. As frustrating as that is with a rare disease, because we don't know of families in, let's say, North Dakota. I don't know an MLD family in North Dakota. So it's going to be a little more challenging. This is just how it goes. So these states, we actually do have active MLD families who are willing and ready to advocate. And actually, Kansas, we have an even better situation because the head of the newborn screening program is a Krabbe disease sibling, and he's already looking to add MLD. So Kansas will be pretty easy. This is the remaining states. I also just realized South Carolina. I don't know why that's an I, not a T. Sorry. I'm big on spelling. These are the states that didn't really fit into any of those categories, or they use another state's lab. So for instance, Hawaii and Idaho both use Washington's lab. So until Washington is screening for MLD, they can't do it. Same thing with the New England states. Everybody except for Connecticut uses Massachusetts. So until Massachusetts is screening, we can't really do a lot in those states, because even if they agreed to screen for it, they physically cannot. So these are the ones that are going to be a little more challenging, but I included in the plan different notes, like South Carolina did add Krebe in 2023, and so they seem to be very proactive with wanting to add new conditions. So in summary, I'm going to go through these. There's a few slides with the different years. In summary, these are the years we can expect and hope for implementation of MLD. So 24 to 26 are the states on the left. 27 is these with, of course, the little asterisk saying that if Massachusetts adds it by 26, then the New England states can follow. 28 will be the big year, because that will be the 3-year RESP alignment states, which is a lot of them. And then I threw in some other ones just again based on their historical addition of conditions. And then Montana and Virginia, I've actually met with the Montana Advisory Board twice, and they are just such a small birth rate state with limited resources, and they use Wisconsin for almost everything. So I figured if Wisconsin adds it, it will still take a couple of years for Montana to add it. And Virginia has a whole host of problems that they actually published a paper about regarding screening for Krabbe disease. And really, I just felt like the paper highlighted everything they need to fix. So hopefully they fix those things, and then they can add MLD. So again, here's the map for those who prefer visuals. So in summary, these 6 states are my highest priority for advocacy efforts based on all of the things already mentioned. All of these have nomination forms publicly available. They all have an active newborn screening advisory board. Most can add conditions fairly quickly. Again, can being the operative word. But in addition, Iowa, New York, and Missouri could also be pursued, because New York already has MLD as part of Screen Plus, which is a consented pilot program, only in 14 hospitals. So it's not, or 11 hospitals, not very many. But the lab already has the capability to screen for MLD. Missouri tends to be an early adopter of LSDs. And like I said, Iowa's being proactive. So we're going to now jump to the essentials, which are about collaboration and communication, listening to understand, and including families. So communication, specifically strategic communication, involves so much more than just writing and speaking. Above all, it involves listening and understanding. Everybody that is involved in advancing newborn screening for MLD or any other leukodystrophy needs to listen to understand each other, communicate clearly, and approach the entire process with a willingness to help and be helped. And that can be a real challenge, especially because so many of us come into this with complicated emotions and lived experience. We see things differently, and it can be difficult to align. But as we know, we all at least have one thing in common. And I thought this quote from Dr. Guthrie, who is the father of newborn screening, says it all. No child should die or suffer disabilities if a simple blood spot can prevent it. We all know and agree that MLD is a horrible condition, and it must be identified as early as possible to provide the parents with options to save their child's life. In essentials, unity. If we are going to be successful, we must listen to stakeholders and communicate well. Working in true unity will take effort, humility at times, and a willingness to learn. But most importantly, we must listen to understand. We must put conflicts aside and not focus on getting credit, as we've already seen the doctors lead the way in. And we must share the information we have about the progress so that we're all on the same page. This has to be a unified effort. We cannot go our own way. Other conditions have tried to do that, and it has not worked well. States don't want to hear from different stakeholders about the same thing who are not working together. We must take an approach that involves all of this in operating transparently, constructively, collaboratively, and ethically, which ethically I listed as not blindsiding the public health labs. To give a real world example, there was a well-intended family in Ohio who wanted to add Krabbe disease to the newborn screening panel there. However, legislators are typically not scientists, they're typically not doctors, and they do not understand what they are doing. And that law has had really negative unintended consequences because they saw that second tier testing for cytosine for Krabbe would cost extra money, and they crossed it out. They have forbidden the lab to do what they need to do to accurately diagnose these children. That's just one example that I've seen happen that has totally changed how I approach this. And so even though I do have a political science degree, I do not believe that we should be legislatively mandating this. There are well-established processes and very passionate people that are behind these. So I think we should work with that. So above all, we must listen to understand. And what does this mean? Listening to understand requires humility, a willingness to be wrong, and the ability to change one's mind when new information is obtained. It humanizes those on the other side and helps us better understand the motivations behind their stance. As one of my favorite teachers says frequently, listening to understand doesn't obligate you to agree, but it often helps you see why the other person feels the way they do, and you may indeed end up changing your mind. Of all the ways I have changed since my daughter was diagnosed 10 years ago, the greatest impact has been from listening to understand. And I know that sounds dramatic, but it actually is very true. My advocacy story has consistently involved listening to understand. My success in reforming the newborn screening system only happened because I listened. In 2016, 3 weeks after Tori died, I attended my first newborn screening advisory board meeting in Pennsylvania. I was grieving, I was angry, but most importantly, I had no idea how newborn screening worked. That first meeting was not a pleasant experience for me. It actually was very, very negative, but I kept going back. And I'm now actually on a subcommittee. I kept learning. And so it was because of learning and listening that I was able to introduce the first bill in 2017, because I sat and I listened and I recognized that Pennsylvania had far larger problems to solve than just adding Krabbe disease. So I recognized that I didn't fully understand how it worked. I learned from all the stakeholders, and by acknowledging their expertise and bringing them together in the same room, we truly now have one of the strongest newborn screening programs in the country. We can add conditions in 6 months, and we've just proven that with the last 2 RUSP conditions. So I took this bill. This is actually from our ceremonial signing. I know it's kind of not showing up well on here. This was 2 years after the governor signed the bill into law, because I accomplished all of this during 2020. Our third attempt went from the committee to the governor's desk in just 2 months, because I listened, and along the way we changed and strengthened the bill. So yeah, I can't say enough about listening. This is really important when it comes to the parental perspective, because parents enter the advocacy arena out of grief, desperation, and sometimes anger, and all of that is valid. We have been wronged. We have had our children taken away from us, and all we want to do is change things. But parents often also feel disregarded, ignored, and unvalued because they aren't doctors. I have been in that situation so many times. As part of my master's research, I did a survey of leukodystrophy families, trying to see what the unmet needs are, and this came out over and over again. And I was surprised, but not surprised, because it's true. We are the experts. We know the disease. We know how it impacts the life. We are the ones who stay on top of the research because we live and breathe this disease. But yet we are often pushed to the side, and I don't want to see that happen. It's also important to remember that decision makers don't know what they don't know. So we need to be kind and help teach them and guide them instead of yelling at them. Like I said, I've done my share of yelling, so this comes from experience. But also, as I mentioned with Pennsylvania, there may be underlying issues in the state that need to be addressed in order to accomplish what we want to see accomplished. And so it's going to take all of us, especially the parents, but it's also going to take listening to stakeholders you may not have thought of, like the hospital association in the state, the insurance federation, which actually they are pretty easy because they are federally mandated to pay for newborn screening. So they were neutral on our bill. But it's just really important to understand that everybody has a reason to be at the table. And then we need to honor the experience and expertise each person brings and be willing to collaborate. All of this is said because of observations I've made of other conditions trying to do this. So to conclude, newborn screening started because of families whose lives had been upended and forever changed. And it is those families who have created lasting change. And I want to make sure that we do the same thing with our MLD families. So I believe that we may see universal newborn screening for MLD by 2029. It's incredibly ambitious, but I think that the path has been laid for us to see this success and to see these families' lives changed. But it will take all of us unified to make this a reality. And we must remember the essentials and the non-essentials while doing everything with respect. There's inevitably going to be conflict. We've actually worked really hard in the advocacy community to come to the table unified, and I hope that we can bring everybody along with us. So with that, I don't know why that G's over there, but there's my email address. If you have any questions, obviously I can take them now too. But thank you so much for listening and for being along this journey with us. Marley, get the mic.
Lisa, can you put your email back up? I didn't have a chance to write it down.
Yes.
Thank you so much.
Some of the stakeholders you mentioned were the hospital association and the insurance companies. What other stakeholders might people not be aware of that you would want to be part of this conversation?
Definitely and again, each state is different. Each state operates differently, and I have a pretty good handle on most of them now, but I'll just use Pennsylvania as the example. Pennsylvania uses Revity as their newborn screening lab, so we had to make sure they were part of the conversation so that we knew that they were ready, that they could implement screening for Krabbe. And like I said, we already know they are prepared to do MLD now, so the states that use Revity can just do it. And there's 4 states plus DC that do that. So we also had to make sure the Department of Health and the follow-up people were in the conversation so that they knew how to present these results to families. We had to make sure that the pediatricians, so the AAP of Pennsylvania, I can't remember exactly what Laura might know, what their acronym is, but the pediatricians in the state, we needed to make sure they were informed and that they got the information from the ACT sheets, from ACMG, or however we wanted to present that information, so that we made sure that the families were getting accurate information, because that's another thing we've experienced as newborn screening has been rolled out, is that families are still being given incorrect information about treatment. And that cannot happen. It's already enough to be told that your healthy newborn has a terminal disease. Families need to be given accurate information. And who else was there? Oh, we had an ethicist involved. We had the geneticists involved. We had everybody that we could possibly think of in these virtual COVID meetings, just to make sure that everybody was on the same page. And like I said, we did change our bill. And the bill was not to add Krabbe disease. It was to fix all these things. And I'm so happy we chose to do that.
Great presentation as always. Lisa, could you talk a little bit about some of the resources that LDNBS have available?
Yes. Thank you, Anna Marie. We have a wealth of information on our website, and Marley and I are constantly coming up with new material. We also have a YouTube channel with some educational things, but one of the things that we've partnered with Orchard and actually now with Forge Biologics as well for the Krabbe side is that we have fact sheets for each state. Right now, well, not each state. We're working on that. We need families to be willing to tell their story. And what we do is we gather their story. These fact sheets tell a little bit so this would be something that the families could leave behind if they went to a meeting with their advisory board or whatever. So it talks about what is MLD, what can be done about it, and then newborn screening within the state. And it's actually a very, very useful document. And I actually don't know how many we have right now, maybe 15. We're always looking for families from states who are willing to share. But so that's one of the things that we can do for advocates. We also, like I said, we have these strategic plans. I have one for MLD and one for Krabbe disease. The one for MLD can most easily be translated to other conditions. yeah, like I said, we have a YouTube channel, social media. Every week I do a state report card. And I talk about how the state is doing with newborn screening and newborn screening for leukodystrophies specifically. And obviously that's always changing too. And then we tell a family story in the state. And so I just have been trying to do everything I can to make this accessible to anybody because it is very, very complicated. And like I said, tomorrow afternoon, I'm doing like more of a newborn screening 101 presentation if anybody wants to attend that to learn more of the complexities of the system.
I attended one newborn screening session, and I was surprised by some of the questions that the panel had asked, specifically around how are we going to help with addressing some of this disparity in access. I know that it's a problem in general that just gets stacked on top of the newborn screening for a specific disease. Is there any plan or a way to address that equity in access across the state, which is not a a small thing to do?
Do you mean access to treatment specifically or access to diagnosis
I
or both?
I guess both, yeah.
One of the challenges in rare disease involves Medicaid, which I would love to fix, but that is way above my pay grade or knowledge. I don't even know where to begin to fix the problems with Medicaid because so many states will only allow patients to receive treatment within their state lines. These are rare diseases. We don't have treatment centers in every state. So thankfully, I know specifically at the University of Minnesota and at CHOP and at Duke, which are some of the primary treatment centers for leukodystrophies, they are very well versed in insurance and in Medicaid and in getting waivers and doing all that. So that's something else parents need to be made aware of is that they don't have to take this on their own because Medicaid is horribly difficult to navigate. So yes, that is one of the considerations that comes in with even each state deciding whether or not they're going to implement a condition. So we have it easy in Minnesota and Pennsylvania because we have treatment centers, we have knowledgeable experts. But what about Montana? You know, these more rural states, that's where it's going to be a more difficult sell. So what we have to do is come armed with that information and be like, here's the nearest treatment center. I mean, they already have to send their patients out of state for other things. So that can be an easily dismissible barrier, I think, from our side, as long as we come prepared and say, this is what the state does. You already send your kids to Colorado or wherever they may send them, Utah probably. Yeah, it's yet another one of those things that I'm so glad there's so many other people working on, like between NORD and Every Life and these other bigger organizations. They're really working to make this better for the rare disease community as a whole. So that'll benefit us as well. I hope that answers your question.
Thank you.
Hi, can I make a comment online?
Yeah.
One of the barriers that exists for pharmaceutical companies in working in rare disease is that we often don't have a good understanding of the number of patients that exist and the number of patients that are in in the US because of the lack of good demographic studies. And so one of the challenges from the pharmaceutical side is to then develop a therapy where we really don't know how many patients there are. And especially for a number of leukodystrophies, we believe that the earlier you treat, the more successful you're going to be. And so the conversation then often gets to newborn screening. And, certainly it's not possible to screen for every disease that pharmaceutical companies are working on in terms of the therapeutic areas. But it does seem to me that there is an opportunity for advocates such as yourself and the group that you're with, to align with a variety of companies to understand what's in their therapeutic pipelines so that there is less catch up when there is an effective therapy available to get these conditions onto the newborn screening panels of various states.
Yes,
And
I don't
I'll introduce
disagree.
myself. My name is Abby Collins. I am a former pediatric movement disorder neurologist, and I worked in leukodystrophies when I was in clinical practice, and now I work at Ionis, leading the Alexander's disease clinical trial.
Thank you. We were wondering who you were. It is definitely a challenge, but there are also, which I will talk about tomorrow afternoon, there's a whole list of criteria, ethical criteria about what can be screened for. And one of the things is that there already has to be an effective treatment, which obviously makes this a circular problem, because how are you going to find the patients if you don't have early diagnosis to try these treatments, but you can't diagnose them if you don't have a treatment. But I will say, I think within the leukodystrophy community, we're all pretty aware of who is working in our space. And so that's helpful. But yes, thank you for that input. Was there another question on Zoom? Oh, that was it. Okay. Do we have any other questions? All right. Well, thank you all so much. And I'm always here if you have questions about newborn screening.